to this Give Me 15-minute education program for medical professionals. My name is Jennifer Searfoss, and I'm the CEO of the Searfoss Consulting Group. We specialize in giving medical professionals peace of mind when it comes to the business of medicine. This presentation will address what you need to know about contracting with a health plan. This session, along with many others, are available for free through iTunes as a podcast or as a video archive on YouTube. Learn more at scghealth.com. One quick legal note. None of the information contained in this presentation should be construed as legal advice. I encourage you to contact counsel if you have questions regarding state or federal law that apply to the concepts covered in this session. With that, let's get started. During this brief 15-minute session, I will cover what is health insurance, the lingo that we use, the different terms applying to health insurance, and then cover the contracting concepts for physicians and other clinicians with third-party health plans. This is not a session intended for employers. I will also provide some sample contracts and also areas for you to consider as you're looking at the contracts between you and health insurers. First, health insurance is an agreement between a beneficiary that we better know as a patient and an insurance company to protect themselves against paying the full cost of medical services. As part of that, the individual patient agrees to pay a premium each month. They agree to pay a deductible, co-payments, and also, if there's certain aspects, they will go ahead and agree to be part of a network. So let's go over what those terms mean. The first one is a premium. A premium, again, is a part of the contract, and it's either a lump sum or periodic payment installments that are to compensate the insurer for bearing risk. So if you think about car insurance or any other type of insurance, including professional liability insurance, you either have a choice annually to pay one lump sum or to do some installments. In the health insurance arena, beneficiaries usually pay on a monthly basis. And that actually then again will allow the insurer to cover that beneficiary. The deductible is part of the policy, it's part of the agreement, and basically those are the first dollar services that the beneficiary will pay. So for example, in high deductible health plans, normally a beneficiary is going to agree to pay something large until the insurer is going to begin payment. And that could be somewhere about $5,000 for an individual. A co-payment is where on each service a beneficiary is going to pay some portion of the service for the services that were rendered during that encounter. And again, it's not going to apply to the deductible. It's separate. So you could have a beneficiary that hasn't hit their deductible that has to pay that full portion. And again, there might be an additional portion, too, that also has to be paid as a co-payment. When you look at deductible and co-payment together, that is called co-insurance. It really covers what is the financial responsibility of that beneficiary or patient for them to access their insurance. So who is this beneficiary? So it is the insured person. And I just want to spike out for you, generally that is going to be the individual that's coming into your office, but also their dependents. When we look at employer-based insurance, they oftentimes will have other persons, including their spouses and children, that are on their own insurance. Versus Medicaid, where that individual person is actually going to be the beneficiary, because Medicaid is based off of an individual, not necessarily a family enrollment. The beneficiary in Medicaid is going to be that person. So let's just talk briefly about who is the insurer. And that insurer is actually going to be the two different types here that I've spiked out for you. So generally, states are going to license health insurance companies, and there's a bunch of different terms. There's no real consistent way across all the states that we talk about those. So I'm not going to go into how we license them, because you'll hear words like HMO that mean something very different in every state. But there are two types of insurance that are really important to think about. The first is going to be the one that is most common, and it is for employer-based insurance. And this is where they contract with a health insurance company to do administrative services only. They bear the risk, the financial risk for that insurance pool, because they're large enough, but they don't want to worry about administering a network of physicians or processing claims. So instead, they contract with a health insurer to do those services. And so that's called an administrative services only agreement. Those are ASO contracts. And this is going to be federal jurisdiction. State law does not apply because, again, it's going to be an employer-based service, and because of that, we also call it ERISA plans. Fully insured instead is where either a small business or like myself, I am a self-insured person. I'm also in an Obamacare health plan, so I love using myself as an example often. But as a self-insured or small business policy where they don't accept the risk, the fully insured, meaning that not only is the health plan administering the network and processing the claims, they're also accepting the risk. So state law is going to apply to the fully insured or FI business. So with that foundation, let's go ahead and turn to what is a contract. So we're going to turn back to 1677 because an act that was done in the English Parliament, yes, here in the U.S. we do still care about good old Queen's Bench, but the English Parliament in 1677 established the common law considerations for contracts. And today all lawyers know about the statute of frauds. It is something that everyone really understands in every other contractual basis other than healthcare, and I'll explain a little bit about that. But the statute of frauds, along with the Uniform Commercial Code, which covers the sale of goods, in our instance we're talking about the sale of services. But again, the statute of frauds really outlines what it is to be a contract. What does it take to be a contract? And then again, the four corners concept basically says that whatever is written down on the, quote, four corners of that written agreement, that is going to be the agreement. And that way that there's a deference to what is written down and not necessarily oral agreements or gentlemen's agreements that happen around the contract, or even bringing testimony into a court about how the parties acted. Instead, we call that parole evidence. So again, really what a contract should be is in writing. It should last longer than 1 year. It needs to be signed by the party that is paying for the goods or services. So again, the total concept here, though, is that the health plan would be would sign this. It doesn't require a bilateral signature, and we'll talk about this. But again, to be a contract, it has to be signed by the health plan. And then the last thing is that it should include the prices for goods and services. Well, here's our issue. Medical contracts are different. It was interesting when Colorado was reviewing these and moving forward on some state legislation to standardize medical contracts between health plans and physicians. The lawyers that were in the legislature just couldn't believe what they were seeing. And they realized that these really weren't contracts, and it's very true. The reason is that the participation agreements between the health plan network and the physician or the other clinician, including like a nurse practitioner or a physician assistant who could be credentialed with a plan dependent upon state law, but it doesn't include an exhaustive list of goods and services covered by the contract. Instead, normally we get a top code to specialty, and it's a sampling. And again, it's only the prices for that time. It's not necessarily updated every time there's a change in the reimbursement rates, because many health plans just aren't doing that, or if they do it, they've got it buried somewhere on their website. Also, there's no disclosure in the contract about a number of policies. That includes how proprietary claims edits are going to be affecting payment. So, for example, probably one of the best examples is for the multiple procedure reduction. There may be a reference in the agreement to multiple procedure reductions, but instead, if there's multiple services done on the same day and there's a reduction or edit that's applied to them, if that is disclosed, it's generally going to be in one of the policies that the health plan is hosting, or it'll be in the administrative guide, which are by reference part of the contract, but are actually not necessarily enumerated in the contract. And again, what I'm really pointing out here is that there's no one way of contracting between health plans. Instead, there's multiple ways of doing it. So one of the other things to keep in mind is that the contract that a physician signs originally to come into the network, so again, there's a credentialing process which is covered in a different Give Me 15 Minutes program. But once a physician or other practitioner is credentialed, the contract needs to go forward to actually be considered in network. That contract is signed by the physician, and then the health plan gets it, but it's not in force until the health plan signs it. Remember, that's part of the statute of frauds. It has to be signed by whoever's paying. So once the health plan signs it and that bilaterally signed contract comes back, that's when the physician or other healthcare practitioner is actually in network and able to bill for services. So the reason it's called bilateral is obviously that it's on both sides. And so because it's on both sides, it is a bilateral agreement. Bilateral agreements are going to have to be achieved anytime there's a significant change or what's called a material change to the contract. So for example, if there is no part of the contract that allows for assignment. Let's say that the health plan gets bought by somebody else. Then when that new group gets bought, that new group is going to need to do new contracts. Now, this is different than unilateral agreements, and I've got some examples of unilateral agreements because this is generally how almost all changes are done to health plan contracts today. But this is where the initiating party, generally the health plan, is going to send a note over to the clinician, and they are going to change something about the contract. And it is assumed that it is agreed to unless the clinician responds back and says, nope, I object. These are going to be done generally, too. They are not mailed. There are some health plans who still do mail. God love them. But there are very few plans doing this. Instead, they're almost all electronic, either in the network bulletins that will come out, so those newsletters that are posted periodically, either monthly or quarterly, depending on the health plan, or it could just be posted on the health plan's website. So again, really, really make sure that you're keeping up to date on what the health plans are requiring. And so also the time frames must be reasonable for the objection. So if you don't want to have this apply, you would need to respond back. But not all unilateral changes have an objection requirement. Some of them are just, here's the notice of what's happening, and there's no opportunity to disagree. So the scope of the agreement, let's start with what is that. So the scope of the agreement is going to establish the responsibilities of each party. So for example, the health plan is going to say, we are going to send beneficiaries to you, and your responsibility is you are going to see them. They also will establish the thresholds for credentialing and privileges. So for example, let's say the health plan requires all of their primary care physicians to hold privileges with an in-network hospital. So that will be laid out also. If there's any credentialing requirements that are somewhat unique to them, they'll lay those out. They will define generally what medical necessity means and basically say that they will pay for services that are deemed necessary and reasonable. Also, if there's any timely filing requirements, they will specify how quickly claims need to come in from you to be able to be paid, but also they will tell you how quickly they will pay the claim. So things to check, term period. This is probably the most important. So all agreements, when they are first signed, have what's called an initial term, and then it's evergreen. I'll give you an example of what an evergreen contract is. And then it will tell you how much notice needs to happen before the contract could be terminated. So for example, generally it's done on that evergreen anniversary. So if June 1st anniversary was in the contract and there was 120 days notice, that means that written notice was due to them for termination by February 1st. It also will specify the notice of changes to the practice. So let's say a new physician comes into the practice, or the practice moves, or there was a change in ownership. They'll specify how long you have to do that. If it's not specifically in the contract, it is in the administrative guide, so make sure you have a copy of the professional manual. Also, documentation requirements. A number of the new Medicaid programs have this, where documentation needs to be, so this is medical records, EOBs, even your 1500s that were submitted will need to be held for 10 years. Good luck with that. Also, office availability. I've seen several contracts that will say, the office needs to be available for so many hours per week. Also, that appointments need to be filled for their beneficiaries within a certain time period. So it just, again, depends on the flavor of contract by the health plan. So moving on, I've got some sample agreements. I'm a big fan of Blue Shield of California now. I'm excited because they've transparently put everything out there outside the firewall on their web portal so you can check it out. So this is a publicly available contract that I'm using just with some examples here. So the first thing just to point out here on a term of what an evergreen contract looks like. So again, this is again from the Blue Shield of California Professional Services Contract for physicians and other healthcare professionals. But it says that this agreement is effective from the date of execution and shall be in effect for 1 year. So remember, statute of frauds, it's for 1 year. And then thereafter, this agreement will automatically renew for successive 1-year terms unless terminated. And then again, here it talks about that it's 120 days notice prior to the annual renewal date. That would be when the termination would have to go in. So again, really good things to make a little appointment reminder in your calendar so that you remember when these are if you're not using a contract management system. Also, one of the things that I find interesting too is that, again, all of the health plans are all over the place on how much notice that they need to give on material changes. And again, in this contract, it says that the provider shall have no fewer than 45 working days prior notice to the effective date of any change in the provider manual and also any changes that are amendments to the agreement. So that is, again, gives you some idea of what the agreement looks like. So if there's a unilateral change to the contract, things that might be considered not material to the contract might be new or deleted codes from the fee schedule. Let's say, again, that CPT or Medicare says that these codes are no longer covered. They may give you notice of that. Generally, if there's notice of those type of changes, there's really no way to object to it because you'd be violating the HIPAA code set if you were submitting them. But also policy changes and other clarifications. So, for example, maybe they want to reference a different manual. They've now divided the manuals between physicians and non-physician practitioners. Maybe there's a new podiatry manual. But also, let's say that it's something that's a little bit more material. It's always interesting to see how these are done about, like, for example, new prior authorization policies. So again, those notices will go out as unilateral agreements, and they may or may not have an objection opportunity. They will also specify how long you have to get written notice back to them, be it 2 weeks, a month. It needs to be something reasonable. 14 days, in my opinion, is the shortest that really you can do. Also, state law may dictate how much they can do as well. They also may do notice changes, timeframes, addresses, other things like that. But again, there's really no way to object to an address. So we've gone very quickly through the wonderful outline of all of the starting point for contracting. If you have questions about credentialing, make sure to check out the other Give Me 15 Minutes program on enrollment and credentialing. So I hope that you've enjoyed this presentation. For those of you that are listening to the podcast or watching the video archive, please remember to rate this recording in iTunes or YouTube. To receive notices about upcoming Give Me 15-Minute programs, other educational sessions, and services offered by SCG Health, please sign up at scghealth.com. Thank you for joining me for this 15-minute education program. This concludes the presentation.